I want to thank the panelists. Those were extraordinary presentations and have caused me to kind of gin up my brain a little bit. Michael, in particular, I want to tell you that reliving the first days of the pandemic have caused me to have a little bit of PTSD this morning. So I appreciate the immediacy and power of your comments, and it's really quite remarkable. As a reminder, I'd like the audience to please submit questions and comments via the chat, and that's located below the webcast video. So I have a couple questions. Michael, I want to start with you since I'm going to need to find a therapist. So my question is this. Back in the, I think, 70s, there was a sociologist, a very accomplished fellow named Charles Perrow, who wrote a book called Normal Accidents. He wrote about nuclear power and other catastrophes. And he said in complex, tightly coupled systems, failure was inevitable and we ought to get used to it. And as you were describing the cascade of things that needed to go right in order for us to stand up testing on the scale that we needed it in our country and across the world, it struck me that there were a lot of things that needed to go right, and any set of things could really make things go wrong. So I'm wondering if you have any thoughts about how, well, first of all, is failure inevitable? And if not, what kinds of investments or redundancies or interventions would we need to put into place to make sure that when the next pandemic comes along, we're good to go?
Well, I think, first of all, the definition of failure is a critical definition, because it doesn't mean you're not stressed. It doesn't mean that you don't have very difficult times, but do you fail? And I think that part of our problem is today, and I think COVID has finally illuminated this for the world, we have lacked creative imagination as to what could happen and why. I mean, here we are right now in this moment where we are watching our healthcare systems break, not bend, because of the issue of healthcare staffing and what's happening with regard to a concurrent event of a surge capacity in cases and a overlapping challenge with people who have just run their 28th marathon in the last 5 days, to the fact of people who are out infected with the virus. I mean, I hear about the Department of Defense adding 1,000 new people in or whatever. Right now, our best guesstimate is that there are probably close to 200,000 healthcare workers in this country, doctors, nurses, and high-level technicians only, who are out right now because of COVID. Well, that in a system that was hanging on by the skin of its teeth is not that. That's failure in that sense that we never anticipated that. We didn't anticipate what would happen with our pharmacies. One of the big box pharmacy companies just announced that most of their locations we close this weekend because they don't have enough staffing. Well, you can't get your drugs. We're already seeing pharmacies that are saying it's 3 to 5 days to get a prescription filled because the warehouse and the drivers that bring the drugs are all in short supply. The grocery store shelves are bare. We were critical of what happened in India and Brazil with the lack of oxygen. Yet we have outbreaks occurring right now in major oxygen generation locations around the country, and we're going to have hospitals in the next week and a half to 2 weeks that are going to be in very short supply in oxygen. That only happens in low middle income countries, right? Not to us. So I think that I add this together because to say that we have to be prepared for category 6 pandemic contingencies like this does mean you basically every day have to deal with it, but we've never really envisioned what would this look like in a way that allowed us to begin to even consider how much surge capacity do we need. And let me just give you one last example that we do that in the world. Right now, one of the most well-funded fire departments in the entire state of Minnesota, and has been for decades, is the Minneapolis-St. Paul International Airport Fire Department. There has not been a plane that's gone down on the reservation of the airport since its inception. The 2 major plane crashes both went down in South Minneapolis 30 to 50 years ago and were handled by the Minneapolis Fire Department. But yet we wouldn't go a day without supporting that fire department the way we do. It's a choice, it's a decision. And so I think to answer your question, Saul, we need to, in healthcare, understand what will it cost us to have more surge capacity capability, including in lab testing, versus what does it cost us it did not have it. And let me just add one last piece. We are on a collision course with destiny right now. I'm convinced of it. China continues to insist on a zero COVID policy. They are willing to shut down large parts of China over what will be an impossible task of stopping Omicron. It's like stopping the wind. And if they do that, the supply chain challenges are only going to get more severe, much more severe, because of the fact that we count on them for so many of our supplies, including major medical supplies and drugs. They are the largest producer of our generic drugs that we use in this country. They're a life-saving drug. So we have to start understanding, what does that mean? And so I think to answer your question is, we are not prepared. We won't be prepared until we agree that we have got to look at this in a very different way.
Thank you for that. It's very helpful. I had a professor once who said that if your bridges never fall down, you're probably building them too strong. I'm not sure we would agree with that. We want the bridges not to fall down.
I agree.
I have a question for Nicole next. And thinking back to the early days of the pandemic, it was very challenging to get tests done in a timely way. And then even when we got the results back, we were always a little skeptical about the results. I can think of plenty of times when the PCR came back and the infectious disease consultant said, that person is still a person under investigation. Don't take him out of precaution. So my question for you is about, helping me think a little bit about how do we deal with delayed diagnosis, or how do we think about the impact of a delay in operations that's the result of either ambiguous test results or delays in the timeliness of getting test results, especially when you have a mass casualty event like the pandemic? Did that affect your organization, and how did people cope with the challenge of the uncertainty about whether the patient had the disease or not?
Yeah, so in various ways. So thanks for that question. The creation of the presumed positive who, may have had a negative test. We're not really quite sure. They still have symptoms. So we're treating them as if they are positive for COVID. So having that timely decision-making, because it was an adjudication process to a certain extent, right? Not just by the frontline team caring for the patient, but just also aided by the consultants and the related infection prevention team supporting just the surveillance of who had COVID within the hospital and where they were. So that was one aspect of it. But that uncertainty and timeliness of making sure everybody agreed caused some disruption to the frontline staff. Is the patient on isolation? Are they not on isolation? Who's authorized to discontinue it? So, and then if so, do they move out of the cohorted unit if that was the process being used at the respective hospitals? And then how does that free up a bed for an elective surgery patient or another COVID patient coming from the emergency department? So those were constant challenges and shuffling and reshuffling. And what happens, it even impacted, other outcomes and quality outcomes of things that we need to worry about, because our teams were really constantly looking at bed placement. How do we get patients through? Who has the appropriate isolation? And really couldn't do the due diligence around some of the other surveillance that we really wanted to make sure of, related to either device maintenance and other things that cause significant harm while we're taking care of a pandemic and a lot of uncertainty in the way that we do things. So how do we handle that moving forward? I think it's really about having coordinated efforts in collaboration and clear communication. A lot of what we had to deal with was just either incorrect perceptions, incorrect communication, and maybe some level of disagreement, but really having to push through that with some standard work around, this is how we're going to do it, understanding that something might change tomorrow. But that was just part of the complexity of being a part of this pandemic and trying to deliver care.
Thank you for that. I want to circle back in a few minutes to Nicole, to you, and to Michael about this interesting concept of the invisible disease. The point that Michael made earlier about symptoms occurring after infectivity begins, all of a sudden that raises an important question about surveillance. And how do you think about surveillance in an invisible disease? Now, I want to come back and ask you about that a little bit, because I'm not sure what we do in order to detect pre-symptomatic cases. And I'm thinking about what we do in oncology and with mammography and so forth. But I want to give you a minute to think about that. And in the meantime, turn to Renu and ask you about phenotypes. So, an unnamed relative of mine came back from a trip, said everybody on the plane was sick. They had fever, they had cough, they were a little short of breath for a while. And I said, sounds like you've got COVID-19. Let's not put a label on it. The question I have around phenotype is, there's so much asymptomatic disease or mildly symptomatic disease. And as organizations, particularly organizations that deliver acute care, plan for managing the pandemic or surges that occur, it's really important for them to know, is this a patient who I think is about to develop prognostically respiratory failure or vasculitis or cardiomyopathy? So in many ways, it's the phenotype that's really important rather than the asymptomatic disease. And I wonder if any of your research can help inform how we anticipate this. In fact, the diagnosis of COVID may be so much less important than the diagnosis of COVID with poor prognostic factors that might result in trouble.
Yeah, absolutely. I mean, I think that computable phenotyping in and of itself is not as granular as the subphenotyping, which then allows prognostication. There's an entire field of patient similarity analytics within informatics in which, like patients, are grouped together and characterized in order to assist with optimal treatment options, prognosis, and sometimes even diagnoses. And so absolutely, Saul, I would agree with that comment completely. And I think that even with COVID-19, there was early delineation in New York City of prognostic factors that I think helped inform planning and triage across the country, across the world, things like obesity, being male, and then increasingly this look at disparities and whether or not those disparities were tied to race and ethnicity, or whether they were tied to viral load, or whether they were tied to a lack of healthcare access. And so I think that there's a lot of utility in precise subcomputable phenotyping in order to assist in prognostication.
In the course of your research and working with your colleagues, I know that you have a lot of input from patients as part of the investigative process. Were there particular aspects of the phenotyping around COVID-19 that patients were particularly concerned or interested in? Did that come up in the course of the work?
Yeah, and I think everybody knows New York City got hit exceedingly hard in March, April, May of 2020. And at the same time as we were pivoting to try to handle the horrific surge of very ill patients, we were also trying to contribute to the public health efforts in order to optimally understand who was at most risk. And so I think one really dramatic example of the value of patient input was as we started noting disparities in the expression of COVID-19, we began to understand that it was crowded households, multi-generational crowded households that were at the most severe risk. In part because, the elderly were having increased exposure, in part because they were often crowded households with higher viral loads. And so I think that that's just one concrete example of how patient input really helped us to put a finer lens on a social determinant, and to think about how to address that social determinant in particular. I think with PASC, there's going to be an exceedingly important role of patients, because it is already clear that there are different clusters of post-acute COVID. And one of those clusters is a symptomatic cluster. And what we don't want to see happen is to have that be disregarded because we as clinicians cannot measure it. And so I think that the importance of the patient voice right now in understanding and delineating post-acute COVID is absolutely critical, because we don't have a test for it yet. We know that there's these different clusters, and one I think is going to be very driven by things like symptomatically feeling fatigue, symptomatically things are moving slower, cognitively I'm moving a little bit slower, these very nuanced things.
Thank you for that. So I want to thank you very much. I want to circle back to Michael first and then Nicole. This idea of an invisible disease, a disease that's transmissible before it becomes diagnosed, what's the implication of that for screening? And when I think about this question, I think about some of the universities in the country that have done a brilliant job of picking up early stage disease, and I think of others that have failed rather dramatically. But I wonder what your thoughts are about that, Michael.
Well, I have to acknowledge I don't think of infectious disease investigation as such as real screening. Let me give you a case in point. I have 5 different colleagues, all who have had college students who are in campuses in December coming home for the holidays. All 5 of them were tested by PCR anywhere from 2 to 4 days before they came home, with the understanding that they wanted to be obviously not infected when they got home. All 5 of them had symptoms within the first 24 to 36 hours of getting home and transmitted to their entire families. The tests that they did 2 to 4 days before were meaningless because, in fact, they got infected in the time period after screening. That's the same way with school testing. Right now, the biggest waste of resources I see in the country related to a formal program is testing people to come back to school, testing them one time. That's like buying a house and having a smoke alarm that only works on the first day you live there, and then it doesn't work anymore after that. Unless you have an ongoing screening program, as you would call it, or testing, you really have a limited opportunity to pick up an infectious disease. So I think that much of what we're doing right now with screening is really terribly ineffective, but makes us feel good. And the point of it is that unless you're doing it very, very frequently, you're not going to be able to detect a sufficient number of infected individuals where you can then have any kind of impact on removing them out of a transmission world to an isolation or quarantine world. And I think that it just doesn't apply much to this disease unless you're doing very frequent testing.
Nicole, go ahead.
Yeah, so I'm going to pivot. I'm glad that Michael addressed the screening testing issue, but I'm going to pivot to the other sort of really weapon we had in all of this, and that was masking, right, and distancing. And the variability at every level in agreement, importance, feelings about masking really was, I think, one of the biggest missed opportunities. So if you really can't see a disease, you can't really understand the timing of infectivity despite testing, but you know that it's communicable from a respiratory standpoint, protect that part of the body and do it consistently. And we know that healthcare workers who wore appropriate PPE, it was not transmitted from their COVID positive patients. We know that the PPE works. So why wasn't there global acceptance of this, which had been proven in past pandemics to work? A mask is our greatest and cheapest tool to help protect everyone at every level during this pandemic. And we just did not, as a as a country, as a really, maybe the world, I don't know, but certainly as a country, did not embrace that at full force collectively as our opportunity to stay safe.
Fair point. And I wonder a bit about, I was impressed with the way that serial testing in certain environments has been effective in terms of identifying disease in congregate living settings, eventually in nursing homes at some universities that were able to pull it off, but it's not a trivial undertaking at all. And I love the fire alarm analogy. And Nicole, I take your point. It's one part of a broader strategy to keep people safe. Let me see if Carmel wants to get the last word, if there are any comments or unanswered questions or observations that you'd like to make, having helped to create the panel.
Well, first of all, I wanted to thank all of the speakers for joining us today and really helping us to articulate what we understand were the challenges, but really giving us a really good detailed sense of how this unraveled over time, and then some subsequent opportunities for us to deal with the pandemic as it progresses, and also some of the future challenges that we are likely to encounter with post-COVID. So again, I want to thank you all, and I'll close with that, unless Dr. Weingart has anything else to say.
The only other thing I have to say is that I also appreciate all the panelists and some of the questions that have come over the transom, and I would like to turn things over to Kathy McDonald for session number 2.